I'm going to be talking about healthcare reform, what's happening in Washington, how it's likely to turn out, and how I think it should turn out. But mainly, Bud is going to be talking about how it should turn out. I'll say just a few words about that. But before I can talk about it, I have to spend some time describing the current system, because it doesn't make any sense to try to evaluate the reform of a system unless you know why it needs reform. So I'm going to be talking with you about the current dysfunctional system, and that takes a lot of courage, because usually people's eyes glaze over if you say, I'm going to talk with you about the healthcare system. And people are taught that it's extraordinarily complicated. I think that people are almost deliberately led to believe it's more complicated than it is by the private health insurance industry, because if you can convince the people that something is terribly complicated, then they won't be so willing to risk changing it. And so even though most people believe it needs changing, understand very well that it's not working, they don't have the courage of their own feelings, because they are led to believe by policymakers who get a lot of their campaign contributions and a lot of their income from the private insurance industry that it is just impossible to fully grasp. And so they should just shut up and take it as it is. So I'll begin by briefly describing 3 features of our health system that distinguish it from every other health system in advanced countries. First, our system is uniquely expensive and uniquely inflationary. Last year we spent about $2.5 trillion, that's trillion with a T, on health care, or well over $8,000 per person in the country. And costs keep growing at 2 to 3 times the background inflation rate. What about comparably wealthy countries? Well, if we look at the 30 members of the OECD, and that's the club of rich nations, we find a startling disparity. In the most recent year, for which figures are available, we spent 2.5 times as much per person on health care as the average for all the OECD countries, adjusted for cost of living differences, 2.5 times as much. The other countries clustered fairly close together. Some of them are very low cost, like Great Britain. Some are higher, like Switzerland and Norway. But still, they do cluster fairly close together, while we stood clearly apart. We were the outlier, and that gap is growing year after year. So clearly our health system is uniquely expensive and unsustainable. The second feature, we don't get anywhere near our money's worth. By all the usual measures of health care, life expectancy, infant mortality, immunization rates, and most importantly perhaps preventable mortality, we rank near the bottom of the OECD countries. Furthermore, contrary to conventional wisdom, we don't provide more basic services. On average, we have fewer hospital beds and fewer doctors and fewer nurses per capita. We see our doctors less often, and we have shorter hospital stays. So these figures give the lie to the notion that, yeah, Americans do have an expensive system, but that's because we want everything. That isn't the truth. We get very little. Canadians, for example, see their doctors nearly twice as often as we do. Worst of all, we're the only nation that doesn't provide comprehensive health care to all its citizens. Some 50 million Americans are uninsured, disproportionately the sick, the poor, and minorities. And most of the rest of us, whether you know it or not, are underinsured, in the sense that we're not covered for every contingency. Our healthcare system, then, is outrageously expensive, yet inadequate and inequitable. Why? How can we explain the paradox of spending more and getting less? Well, the only plausible explanation is that there's something about the system itself, about the way we finance and deliver health care, that's enormously inefficient. That's the only plausible explanation. And here's a clue. The third distinguishing feature of the American health system is that it's the only market-based system among the OECD countries. In fact, it's not a system at all, but a hodgepodge of different commercial arrangements that exist more or less independently from one another. The other countries all have national health systems. Some are single-payer systems, which means that all healthcare funds, whatever their source, are funneled through a single public agency, which then coordinates the distribution of the resources. Some have multiple payers, like Switzerland and the Netherlands, but the system is tightly regulated so that everyone is covered, and prices and benefits are uniform, and the insurers are nonprofit. So, to recap the three distinguishing features: uniquely expensive, uniquely inadequate, and a market-based system. I believe the underlying problem with the system is precisely our reliance on a commercial market in healthcare. Most of the other problems in the system flow from that one. Alone among advanced countries, we treat healthcare like a market commodity instead of a social service. Thus, we distribute it not according to medical need, but according to the ability to pay. But there's a great mismatch between medical need and the ability to pay. In fact, those with the greatest need are precisely those least able to pay. So while markets are good for many things, they're not a good way to distribute health care. People who are well insured may get an MRI they don't need. They may get many MRIs they don't need, while people without insurance may not get an MRI that they do need. The characteristic of the system of providing all kinds of tests and procedures to well-insured people or wealthy people, and billing for those tests and procedures exorbitantly, reminds me of a joke about a woman who had a pet duck, and her duck wasn't doing so well. So she brought the duck into the veterinarian's office, limp duck, very upset, and she said to the vet, something's really wrong with my duck. Take a look at my duck. And so he put the duck on the examining table, and he looked at the duck, and he said, "Madam," he said, "your duck is dead." And she said, "Oh no, maybe he's in a coma or something. Maybe you could do something." And he looked again at the duck, and he said, "No, I'm quite sure your duck is dead. You could have a second opinion if you want one." And so she said, "Well, yeah, I think I like that." And so he said, okay. So he opened the door to a side room, and in came a Labrador retriever. And the retriever bounded up to the examining table and stood on his hind legs and put his paws on the table and kind of walked on his legs around the table, sniffing at the duck, and then sat back on his haunches and looked up at the vet and shook his head sadly. So he went into the room, and out of the side room came a cat. And the cat leapt up on the table, and the cat walked all around the duck, sniffed at the duck, sat back on his haunches, looked up at the vet, sadly shook his head. So the vet said, "No, your duck is dead." So she pulled herself together, and she said, "Well, how much do I owe you?" And he said, "That'll be $200. And she said, $200 just to tell me that my duck is dead?" And he said, well, no, that part cost you $20. He said, but you throw in the lab test and the CAT scan and it really mounts up. So that's what we have in our system. Furthermore, successful markets expand. They don't contract. That's Economics 101. All businesses aim to increase revenues and maximize profits. That's what they do. Hospitals in the US, for example, often advertise their services. Come and get a total body MRI scan for your wife for Christmas, the best gift you could give her. You know, this kind of stuff the hospitals do. Like all businesses, they want more, not fewer customers. So each element in the health market is working to grow, even while the country as a whole presumably wants the system to contract. So even on the face of it, in its own terms, it makes no sense to have a market-based system when you want it to contract. Let's look more closely about how the healthcare market works. Most Americans receive tax-exempt health benefits from their employers, who pay insurers a portion of the insurance premiums, these days a smaller and smaller portion. But not all employers offer benefits. It's strictly voluntary. And when they do, the benefits may not be comprehensive. Increasingly, then, employers cap their contributions so that the burden of increasing costs falls entirely on workers. And workers, in turn, often turn down benefits even when they're offered because they can't afford their growing share. The insurers with whom employers contract are mostly investor-owned for-profit businesses. They try to compete to get employers' business while maximizing profits at the same time by stinting on medical services. In fact, the best way for insurers to compete is by not insuring high-risk patients at all, by limiting the coverage of those they do insure, for example, by excluding expensive services like bone marrow transplantation, and by passing costs back to patients as deductibles and co-payments and claim denials. We are the only nation in the world with a healthcare system based on dodging sick people. That's what all of this is about. These practices add enormously to overhead costs because they require a great deal of paperwork. They also require creative marketing to attract the affluent and healthy and avoid the poor and the sick. Not surprisingly, then, the U.S. has by far the highest overhead costs in the world, and overhead is one of the fastest growing components of our system. So now let's follow the healthcare dollar as it wends its way from employers toward the doctors and nurses and hospitals that actually provide the medical services. First, private insurers regularly skim off the top of the premium dollar a substantial fraction of the premiums, around 20%, for their administrative costs, marketing, and profits. The remainder, the 80 cents, is then passed along a veritable gauntlet of satellite businesses that have sprung up around the health industry because there's so much money in it. These include brokers to cut deals, disease management and utilization review companies, drug management companies, legal services, marketing consultants, billing agencies, information management firms, and so on and so on and so on. They, too, siphon off some of the premiums, including enough for their own administrative costs, marketing, and profits. Probably no more than 70 cents of the healthcare dollar, and that's generous. 70 cents of the healthcare dollar actually reaches the providers who themselves have high overhead costs to deal with the requirements of multiple insurers, often bent on avoiding payment. Cutting overhead in half would save the system several $100 billion a year. And we can disagree about that amount. At least $200 billion a year. More than enough to cover all of the uninsured. In the past, there have been attempts to reform the system incrementally. Mainly, these have been efforts to counteract the harshest effects of the market by subsidizing care to people who would otherwise go without, and discouraging demand by stratagems such as managed care. But all attempts to reform the system piecemeal have run into the following dilemma. If we expand coverage, then costs inevitably rise. And if costs are lowered, then coverage is inevitably reduced. Think about that. If the system stays essentially as it is and we just tinker around the edges, coverage and costs have to move in the same direction. The only way both to increase health coverage and reduce costs is to change the system entirely. If you take nothing else away from this talk, I hope you'll remember this one point. Coverage and costs cannot move in different directions if the system stays the same. With that as background, what can we say about President Obama's health care plan, the Affordable Care Act, which was passed 2 years ago? Well, first, let's look at the substance. Obama's stated purpose was to control costs so that we could expand coverage. After all, if it weren't for costs, coverage would be a piece of cake. Right? Didn't care how much it cost, you could cover everybody easily for everything. Yet from the beginning, the president made it clear that the private insurance industry would continue to be the linchpin of our system. Moreover, not only would it remain the linchpin, but he would deliver to insurance companies millions more customers, billions more dollars, and those customers would be required to purchase policies at whatever price the companies charged. And he would take about $500 billion of public money to subsidize those purchases. This is a recipe for price inflation. There is nothing in the plan that would control costs. Yes, some of the worst abuses of the insurance companies would be curbed, such as excluding people with pre-existing conditions. But companies could respond by simply raising their prices. There is nothing in the plan that would stop the overuse of tests and procedures, as in the CAT scan and the Labrador Retriever. Providers would still be paid to do more of them on a piecework basis. Without measures to curb the rise in premiums and the overuse of expensive care, there would be no control. There will be no control of costs. Well, you might say, what about the fact that the Congressional Budget Office, the CBO, has projected that the plan would actually save money over 10 years compared with doing nothing? That's true, but you have to remember that the CBO looks only at costs to the federal government, nothing else. It doesn't look at the health system as a whole. Looked at that way, the plan might cut the federal budget, but only by moving money out of Medicare into the private sector and Medicaid. The CBO's projections don't include any consideration of inflation in the private sector. In my view, the ACA, the Affordable Care Act, will never be fully implemented as written. If the Supreme Court declares it unconstitutional, or there's a Republican sweep in November, that will be the end of it. But if, as I suspect, it is not declared unconstitutional, and as I hope, President Obama is reelected with the Democratic Senate, at least, I think the ACA is doomed anyway. It will gradually unravel. Costs will rise even faster than before the law was passed because it is so inflationary. There will be multiple legal challenges to the requirement that states set up insurance exchanges, and the bureaucratic challenges of monitoring insurance companies will be overwhelming. Just as an example, one of the provisions in the law is that insurance companies cannot spend less than 80% on healthcare, on medical services. They can keep a maximum of 20% in profits and overhead. That's in the law. Now, what they spend on medical services, they call their medical loss ratio, and that language is very telling. They want to keep that as low as possible. They want to keep the executive salaries and the profits as high as possible. And when they advertise to investors, they boast about having a low medical loss ratio. This is an attractive feature to investors. Well, suddenly now, with the ACA, if it goes into effect, and in this regard it is, it's no longer to their advantage to say that they have a low medical loss ratio. They must keep that ratio at 80%. So what they will do, and what some of them are beginning to do, is simply redefine what's medical care and what's overhead. So they say, well, yeah, some of what we have called marketing is really connected with medical services, so that's really in that 80%. The law has provisions to stop some of the abuses of the insurance companies, but particularly physicians realize that almost all of these regulations can be circumvented in one way or another. And to try to stop it, when you have a financial incentive to provide fewer services, which they certainly do, to try to stop them from following that incentive by regulations, first of all, is impossible. And second of all, it would require a huge bureaucracy that would gobble up a lot of the healthcare dollar. The only way to sustain an inherently inflationary system is to reduce benefits or increase deductibles and co-payments, or both. That's the only way they could stagger along with this. The result is that people may end up with insurance that's inadequate because the benefit package has shrunk, or is too expensive to actually use because of high deductibles and co-payments. Health insurance is not the same thing as health care. We often use those terms interchangeably, but they're not the same, not by a long shot. And that's probably the second point I would most want you to remember from this talk, that insurance is not the same thing as care. People can have insurance that's of little use to them when they're sick, and remember that. I believe the only answer is a national system like every other advanced country has. We need to get everyone under the same tent so we don't have this shell game in which we shift costs from one part of the system to another. This would be tantamount to extending Medicare to the entire population. But I'm going to leave to my husband, Dr. Relman, to go through the details of the reforms that he would like to see, and to some extent I would like to see too. We do have some disagreements, and I hope after he speaks that there will be a chance to air those and to get a lot of discussion and questions from you. Thank you.
Well, thank you, Marcia, for the introduction. And let me say that I agree essentially with Marcia's description of the problems with the American healthcare system. I think her diagnosis is correct. I agree with her that the Affordable Care Act Obamacare, if you will, has a serious deficiency in that there is no reliable mechanism for controlling rising costs, as she has described, and it does enshrine, that's the word that Marshall likes to use, and it's an apt term, it does enshrine the private insurance industry to play an increasingly important role in providing the resources for health care and having increasing power to determine what will be spent on health care. And I agree with her that the private insurance industry is part of the problem. I take an even more negative view of private insurance than she may. I believe it's a parasitic industry that should not exist. I am old. I am old enough to have been practicing medicine at a time when there was no private insurance industry. When I started out in practicing medicine, that was immediately at the end of World War II. There were very few insurance companies that provided medical insurance anyway. It was not a profitable or significant business, and those few medical insurance companies that existed were mutual companies, and the Blue Crosses and the Blue Shields were not for profit. And it wasn't until healthcare became monetarized, that was the term that the late, very distinguished health economist at Columbia University, Eli Ginsberg, used to describe what happened to healthcare when Medicare and Medicaid were passed in 1965, when huge amounts of new money flowed into the system. And more important than that, with Medicaid, with the existence of Medicare and Medicaid, an insurance company that wanted to take the risk of insuring health care could be reassured that there would be very few people who would need health care and would come to the hospital and wouldn't be able to pay, so that there was money to pay for health care, and it was all right to ensure a system that was going to be supported by Medicare and Medicaid. And that's when health insurance became a profitable industry. That's after Medicare and Medicaid. That's when Blue Cross and Blue Shield associations began to change from a not-for-profit mutual organization to an investor-owned organization. And that's when you began to have the development of huge for-profit corporations, which ended up with United Healthcare and WellPoint and what's the group in Hartford?
United Health?
No, in Hartford.
Oh,
Aetna. And companies like that began to take over. So I think that we need to get rid of private insurance, and I agree with her that's a major part of the problem. However, where we disagree, and we disagree under the most cordial and friendly, we have delightful discussions at the breakfast table on this issue. I think that despite its deficiencies, despite the fact that the Accountable Care Act strengthens the role of private insurers and has no adequate cost control, despite that fact, it's better than doing nothing, because it does expand insurance coverage. It moves towards universal coverage. It's still, although if it were fully implemented, it would add maybe 30 or 32 million more people to have insurance coverage, half of whom would be through expanded Medicaid programs that would be subsidized by the government, and half of whom would be through private insurance exchanges, which the government would also help subsidize in the private sector. They would still leave another 25 or maybe even 30 million people who are uninsured. So although the Affordable Care Act does not achieve universal coverage, it's a step in that direction, and it says something about what the country wants to do. It says that we recognize health care as a major problem. We're trying to solve it. We're trying to get as much coverage as we can. We're trying to reduce the abuses of private insurance. Marcia didn't have time to mention, but she agrees with me that there are, among the 2,700 pages of the Affordable Care Act, there are provisions for trials of new ways of paying for health care, which would encourage more efficient and less expensive health coverage, but no guarantee that they'll work. So I tend to say the glass is half full. She says it's half empty. And to really understand the difference between us, you have to see her car. She has one bumper sticker on her car, which she's had for many years. She's not a bumper sticker type person, but she has one bumper sticker, and that bumper sticker says, "I doubt it." And if I still had a car and I had a bumper sticker, it would say, "I'm hoping for the best." So, now, I'm convinced that the impending national cost crisis and the bankruptcy of our healthcare system will not be averted unless there is a much more drastic and systematic approach to healthcare reform. Marcia and I are on the same page there. We will have to replace all our insurance systems, public and private, I think, with a single public plan that guarantees universal access to prepaid, comprehensive care. And this plan will have to be funded by a progressive health care tax, an earmarked health care tax that all citizens, including government officials and legislators, must pay according to their means. Now, prepaid comprehensive care funded in this way would give government firm control over its total health expenditures. It would, by deciding how much the tax would be, the government would be able to decide how much it wants to spend on health care. But I believe that it should leave decisions on the specific use of the available resources that government wants to apply to health care where it should be, in the hands of physicians and their patients. By setting the rate of the health care tax, government would in effect be capping its costs. Any medical services provided outside such a system would have to be at the patient's expense. And it would be, again, a national decision as to how comprehensive the range of services should be. Now, to provide this kind of prepaid comprehensive care, we will need a reorganized medical care system based on private, nonprofit, multi-specialty group practices in which physicians are paid largely or entirely by salary. Because, you see, if fee-for-service payment, which is the basis for the present insurance system, fee-for-service system, is to be largely or entirely replaced by a prepaid, capitated payment, which I must say that, I want to make it clear, most thoughtful, well-informed experts on healthcare economics are coming around to that point of view. Most people, the smartest health economists in the country now, a nonpartisan view, a technical view of the system, agree that fee-for-service payment, which is tied to insurance. Insurance is a way of transferring fees from a payer to the provider and taking 20% or 25% for yourself in the course of that. If fee-for-service is going to be replaced by prepaid system, a capitated system, then you must have medical care organizations that can take that capitated payment. They're taking care of 5,000, 10,000, 20,000, or whatever number of patients at a per capita basis. Take that total amount of money, accept the responsibility for providing comprehensive care, a defined range of benefits, and be accountable for what they provide. But then it has to be an organization that is capable of satisfying the expectations of physicians that they're going to be paid fairly for their efforts. And that has to be done collectively, the way it's done at the Mayo Clinic or Geisinger or Kaiser, where they take the total money that they get and they pay their doctors' salaries, which their physician management has decided is reasonable, and all the doctors work together as a team. They don't compete with one another to take patients away or get their share of the dollar. They're paid a good salary, a very competitive good salary with excellent fringe benefits, and they're expected to work together as a team with nurses and nurse practitioners, social workers, and other healthcare professionals to provide the best possible care they can for their patients with the money that they have. That's what we need. And in order to do that, you have to have a new organization, a multi-specialty group practice. The kind of multi-specialty group practice that I've described in some detail elsewhere in publications that I've written and the book that I've written, would be ideal for this function. You could describe it as small versions of the Mayo Clinic or Kaiser, community-based, appropriately sized for the communities that they serve all over the country. Now, there's much reason and considerable empirical evidence to suggest that group practices can deliver care more efficiently than unorganized physicians in solo or small single specialty partnership practices who compete for income and depend on fee-for-service payment, as is the system now. Multi-specialty groups usually include adequate numbers of primary care physicians who integrate and moderate the procedure-based behavior of the specialists. Again, there's almost universal agreement among people who understand healthcare that a good, efficient healthcare system that provides good quality service to patients and enables the medical care system to work as efficiently as possible has to be centered around primary care. Primary care has to be the organizing principle, and the primary care people, whether they're nurse practitioners or physicians in primary care, have to work as a team with the specialists, and there can be no competition. It's a group arrangement. Most experts agree that substantial savings as well as improved care can be anticipated when primary care physicians collaborate with specialists in well-organized groups. Without the fee-for-service incentive, prepaid salary groups of this kind are less driven to unnecessary or duplicative services, and if the system is funded entirely by government without involving bills, the costs of insurance overhead are avoided. All that 15 to 25% that the private insurers take off for simply being middlemen is avoided. And also, something that's not sufficiently understood, the enormous amount of fraudulent billing and crime involving fraudulent billing, which experts tell me, people in the private and in public office have told me, that fraudulent billing takes a minimum of 5% of the total amount of money we spend on health care. Some experts say it's 10%. If there are no bills, there can't be any fraud. This is the potential savings would be enormous, and without the incentives that fee-for-service provide for providing having lab tests and CAT scans on dead ducks all the time, without that enormous incentive for overdiagnosis and unnecessary procedures, you can save an enormous amount of money. People, again, experts, been studying this. People at the Dartmouth Institute and elsewhere around the country have been looking at this. A conservative estimate is that 1/3, this is in addition to the money that we would save by getting rid of private insurance. That's 15 to 25% of everything that we spend on private insurance, estimated to be, as Marcia said, somewhere around $200 billion. In addition to that savings, experts who look at the system say that we could save at least a third of what we now spend on health care by avoiding unnecessary, duplicated, ineffective diagnostic and therapeutic procedures. The amount of money that we would save would be more than enough, as Marcia has pointed out, to provide coverage for everybody and to provide comprehensive medical care for almost all medical needs. There might be some very special things, elective cosmetic surgery and fancy things that people would want that wouldn't be covered by the system, and people would have to pay out of pocket if they want it. But you could save so much money that you could provide good care for everybody. Furthermore, there'd be more than enough, if there are any students or house officers in the audience, be more than enough to cover the costs of medical education and medical research. It would be a drop in the bucket. This coming year, we're going to spend almost $3 trillion on health care. If we could save 30% of that as a minimum, there'd be more than enough to take care of the costs of medical education for everybody. It could be free. People wouldn't have to graduate from medical school with huge debts and be forced to go into specialties that make a lot of money because they're so much in debt. Now, the question is, how do we get there? I mean, how are we going to move to the system that I'm describing? The answer to that question is slowly, with great difficulty, in incremental ways. But there are movements underway. In some states, for example, there is a concern that the organization of healthcare, the delivery of healthcare through groups and prepaid arrangements for comprehensive care can be started, as in here in Oregon with your governor's plan to start with Medicaid patients. And in Vermont, they've passed a law which says we'll start by setting up a single payer system, getting rid of private insurance, and then we hope with waivers and persuading the doctors to get the doctors to form the organizations that will deal with the single payer system. But physicians are ultimately going to have to be part of the solution, in the sense that they're going to have to agree voluntarily that it's better to practice medicine in groups than privately and individually. Are they doing that? Yes, they are. The evidence is that at the present time, more and more young physicians are choosing to be employed by multi-specialty groups. That's a relatively new phenomenon. The number of doctors, practicing physicians in this country now being employed by multi-specialty groups is somewhere around 200,000. That would be maybe 25% of all practicing physicians, and that number is increasing at the rate of about 10% a year. Now, the problem with that hopeful sign is that, first of all, most of these groups have to function in a system which still pays on a fee-for-service basis. We don't have a single-payer system. We have a whole lot of private insurers, and we have Medicare, and so they're paid on a fee-for-service basis, and physicians are being paid mostly. They may get a base salary in most of these groups, but they're mainly being paid on the basis of what they bill and collect, with a few exceptions. Kaiser, Mayo, Geisinger, Scott White, Marshfield, and other groups, increasing numbers, say, no, we'll collect what we can on a fee-for-service basis, or some of them have their own insurance system. And we're getting a capitation payment. We're getting a premium from the patients who are in our insurance system. We're going to lump all that money together, and we're going to pay our doctors largely, if not entirely, by salary. But it's a slow process. Most doctors still feel more comfortable eating what they kill. And so that if they're really hungry, they can kill some more. But an increasing number of physicians who are living in the salaried systems are finding that's a good way to live too. You get well paid, and your lifestyle is much better. You don't have to worry about the costs of setting up an office. Malpractice is paid for, good retirement benefits, good educational benefits, and it's a good style of collegial style of practice. Furthermore, an important fact, Marcia's told you some things to remember. Remember this, by the end of the next decade, half of all the doctors you're likely to encounter will be women. When I started out in medicine, I was in a class of 120, there were 3 women. And Marcia also lived through an era when women had to struggle to establish their legitimacy as members of the medical profession. Now, fully 50% of applicants of entries into medical school are women, and women like to be part of a medical organization. They like to be able to share their professional responsibilities and their professional time, because obviously they are interested in family obligations as well. And in general, women find the collegial style of practice in groups very comfortable. So that's going to make a big difference. However, there are two problems looming on the horizon. The insurance companies are not going to go away that easily. They see this change coming. They understand that group practices may become a very important part of the healthcare system. They want to own the group practices. So now you have the WellPoints and the United Healthcare and again, what's the name? Aetna. They're out there shopping around and buying up practices and forming their own groups. They want the doctors to work for them so they can control the market. A very, very bad development. And the second thing is that hospitals, which are also, unfortunately, in today's commercialized healthcare system, behaving like businesses, competitive businesses, hospitals feeling threatened by the coming change want to be able to control the doctors. And the hospitals, like the insurance companies, are buying up practices. And that's also, in my opinion, a bad idea. So we have to hope that the medical profession will be wise enough in the long run to understand that they have to manage their own affairs obviously under federal regulations that will make sure that they're not for profit and that they operate in the way they're supposed to operate, but that they manage their own affairs and don't sell their professional independence to insurance companies or to hospitals. It's slowly happening. The question is it going to happen rapidly enough to prevent the system that Marcia has described from imploding? I don't know. I think it's a race. I think it's quite possible that despite the fact that more and more doctors are seeing the benefits of organized practice, despite the fact that some states are seeing the benefits of maybe setting up single-payer systems, despite that, I think it's quite possible that the healthcare system that we have now will gradually deteriorate to the point at which we will have to recognize that something has to be done. Winston Churchill is famously reputed to have said about Americans when challenged by his colleagues during World War I on the failure of the Americans to come in on the side of the Allies, Winston, why are your American friends dragging their feet? Why don't they come in and help us defeat the Axis? Churchill was reputed to say, don't worry, they will. Americans always in the long run will do the right thing. But he said, only after they've tried everything else. And I think that it's quite possible that we will try everything else, that we'll try to hang on to this system. The we being the people who are making all the money from this enormous commercialized system and don't want the system to change. They will hang on, trying to keep it alive, but sooner or later, it has to change. Those people who say to us, to the doctors and to lay people who advocate for single-payer reform, who say it's pie in the sky. You know, it may be a beautiful idea, but it's a dream. It's totally politically impossible. It's off the table. Forget it. No, it won't go away. It won't go away because it's the only system that can work. And I say to people who challenge Marcia and me and people like us being unrealistic and impossible, I say, okay, you suggest a better system. You suggest a system that covers everybody as they should be covered, with decent care at a price that we can afford and that is economically sustainable. Give me a plan. There's no plan that will work that doesn't have a single payer, a single public payer, and organized, not-for-profit health care delivery of the sort that I'm talking about. There are many ways to get it. It'll happen slowly, but sooner or later, I'm convinced we must have a single-payer system. Thank you very much.
No one should have to choose between rent and life-saving medical care. That's simply not right. I don't care where you're at on the time span. I think we as Americans know that if we see somebody on the side of the street suffering, we're going to do something to help them. Why have we not adopted that same type of mentality into the bigger scope of medical care to know that we have to help our fellow person, because sick people is a sick society, right? We all like to go out to eat every once in a while. So do we want our food handlers or our servers to be sick because knowing that a lot of that population doesn't necessarily have health insurance or has pretty minimal care? Do we want them to be sick handling our food, then to pass that on to us? No. Sick people, sick society. Healthy people, healthy society. So right now what we're trying to do is really generate that energy, educate, engage people, mobilize people to fight for this greater good, which is healthcare is a human right. I mean, think about that. Healthcare is a human right. Me personally, I've really enjoyed working with Mike and a lot of the other doctors and physicians and just people who have been involved in this movement. What we want to do as a speakers bureau, right, so all of us here, is to not only become educated on healthcare and what healthcare means to us and what it means for the bigger country. I know the doctors who just came and spoke did a great job of sort of summarizing what the system looks like and where it potentially needs to go before it's too late, right? And so in this, we want to become sort of that person, that pillar that people look to for information, right? When we go out and talk, say for example, house parties, we want to go out and we want to engage people and meet them where they're at. A lot of people still have this idea that, all of those bullet points that you hear on the Fox News or any kind of media, right, those really emotionally charged bullet points, we need to be prepared to be able to be sound in handling that, because we don't want to engage. We know that we will benefit as a society and as a country if more people have medical care. It's as simple as that. So when we go and we engage in these, we have to be very passionate, very enthusiastic. We have to understand that people are at certain areas in their thinking, and we have to be those teachers, right? I'm a teacher, so I can use the teacher language. Okay, we have to help sort of nurture their understandings and sort of re-guide their misunderstandings in a direction that's going to have a more conclusive end result in terms of what they come to believe and know to be true. People, okay, across the board know that we want to help people. We know that our system is destined to fall. We know that we spend $8,000 on average per person per year. We spend more money than any other country, and yet 50 million people still don't have health care. So as we go and we do this, and as we really build our Speakers Bureau, it's really important that we as people recognize that everybody has needs and everybody has understandings, and we can just facilitate and guide those needs and understandings. And a lot of us here may just be, right, just starting our journey on the understanding of healthcare and where we're at right now in this state. However, we go bigger picture. We think 3 years from now. We've been working on this, I know Mike and Betty have been doing 20 years now, right? Yeah, Betty for 20 years, Mike pretty strongly for the last 6, 7 years. Okay, so we know that people have put in this energy, and now we are on that peak where people say, dude, I've had enough. Okay, the fact that medical costs are the #1 reason people go bankrupt in our country today, that in and of itself says, something's not quite right. What can we do? We are a network of speakers, right? We are here to support each other, to guide one each other, to help one each other. I know Hank and I have done quite a few presentations now together, and it's almost like I'll be up there speaking, and I just looked at him because he always has these little comments that he, places throughout. So as and when he doesn't speak, I'm like, but you normally talk here, so where are you at, buddy? And so we have to understand that, though. And so if we don't feel like we're there in our understanding, that's okay, because that's what you have everyone in this room for. And so we don't go to people's houses and speak with just one person. We go with 2 or 3 people who can help really support us and provide that pillar for us, because we're not always going to know everything. That's not expected. But what we do want is people to have a lot of energy, to really feel passionate about what you're doing, so that way people too can be like, I may not agree, but you happen to really be passionate about this, so maybe you're onto something, right? And that will sort of inspire them not to want to argue points that you just know. I mean, come on. There are some things that people say where you're like, really? Like the universal type thing. Really? We know that healthcare is a public good, right? We know people can benefit from that necessity. We also believe that education is public good. We also believe that the fire department is public good. We also believe that police is a public good. We also believe that roads and bridges, rebuilding and restructuring and the infrastructure is a public good. So why not medical care? Why not?